This is the parasagittal section CT scan of a patient with bilateral chronic pansinusitis with essential involvement of the frontal recess, the frontal sinus, and patchy involvement of the ethmoids. The presenting symptoms are recurrent headaches, which get exacerbated on air travel, as well as sometimes normally, with recurrent episodes of nasal congestion and nasal obstruction. As we can see here, a large suprabullar cell is pneumatizing along the skull base, along the posterior wall of the frontal sinus, into the frontal sinus, and because of the large suprabullar cell that we see here, along with the type 3 cell, type 3 Kuhn cell, the frontal recess is markedly stenosed and restricted. Also, one can see here, in the other side of frontal sinus, we can see how a large T3 cell is occluding the frontal recess and is pushing it backwards. So in this situation, we have both sides frontal sinusitis, the recess being blocked, and on both sides, the blockage reasons are different. On one side, it is the suprabullar cell that becomes the impediment, and on the other side, it is the type 3 Kuhn cell, which occupies just about 50% of the height of the frontal sinus anteriorly, with a small suprabullar cell posteriorly, and the frontal recess now drains between these two cells. As you can see, there is patchy ethmoidal sinusitis, some maxillary sinusitis with occlusion of the osteomedial complex. The nasal septum, at least posteriorly, appears to be reasonably straight, is not causing any problems. The superior turbinate on the right side, as you see on this section, is partially pneumatized, also leading to such certain occlusion of the sphenoethmoidal recess. A large posterior ethmoidal cell on the left side, however, also demonstrates above the basal lamella or the horizontal attachment of the middle turbinate to have opacification. And this coronal scan shows you what I was speaking about just before. It is on the right side, we have a large cell which occludes our frontal sinus and recess, and the frontal sinus itself has opacification, whereas the large cell seems to be clear. On the left side as well, there is a large cell which we saw as the suprabullar cell, which was causing obstruction. The agar on the right side is clearly visible, above which is the large cell that occludes the frontal recess. As we see here, the number of cells increase, and now we come into a T3 sort of configuration where there is the agar and there are two cells above the agar one above the other, around which the frontal sinus eventually and the frontal recess drains above these cells. So understanding the frontal sinus anatomy on a case-to-case basis is very important in successfully opening the frontal recess or the frontal sinus, especially in patients where there is selective opacification or sinusitis of the frontal sinus, because merely opening the ethmoids or the sphenoid would not lead to complete relief in these patients, and not understanding the anatomy of the individual cells, the blocks that make the frontal recess, whether it is Kuhn cells or whether it is the suprabullar cells, can make the frontal sinus approach very difficult and inconsistent and give rise to unsatisfactory outcomes after sinus surgery. From the right side, we begin with a standard uncinectomy and proceeding to a middle laryngoscopy. Just like in our previous videos, we'll focus on a cell-by-cell approach and a landmark-based surgery to be able to be confidently locate and precisely open all sinuses. Here we're using a frontal sinus turret to backfracture the uncinate process. Once we have engaged the frontal sinus ostium. Now, it's very important to understand that since the frontal sinus is the key area to be opened in this surgery, the uncinate process has to be removed all the way up, and no remnant of it can be left. Otherwise, the frontal sinus recess would be very difficult to open. So we can use a straight true-cutting forceps to increase the maxillary sinus enterostomy. Now, the maxillary sinus enterostomy, even if, let's say, it does not have any polyps, is still a very important fundamental procedure because it opens the osteomycal complex, and also because of the fact that a large, reasonably made maxillary sinus enterostomy is a very important landmark into our orientation towards the posterior anterior ethmoids and the sphenoid sinus. So when in doubt regarding the levels of these sinuses, our entry inside these sinuses, the vertical, the horizontal, and the transitional enterostomy ridge often guides us very well and keeps a surgical perspective while operating in a bloody field or in a field where landmarks have been altered. As we see here, we're using the microdebrider blade, a straight blade for now, to increase the maxillary enterostomy. Care being taken to increase it inferiorly, slightly posteriorly. We do not have any superior lever because of the orbit. And posteriorly, one must not make it flush with the posterior one because then that leads to potential trauma to the sphenopalatine artery. It can be managed using simple bipolar forces, but in such situations where we do not want a very big access, it is best avoidable. Here we are using a navigator probe to map our surgical landmarks time to time to be able to show that there is no tracking error and we can corroborate what we see in front of us vis-a-vis what the navigation system is showing to us on the CT console. As we see here, once the enterostomy has been done, we are trying to negotiate our way with the bulla still intact inside to find and remove the posterior wall of the agar nasi or the first cell. We have still not opened the bulla, and then this could be called the intact bulla approach, though of course we would be removing bulla because of the opening the ethmoids. But we are just seeing how we can insinuate our instruments with the bulla intact and try to see what we are seeing in the frontal sinus and the frontal recess. As we had already seen, the frontal anatomy here is slightly complicated with presence of multiple cells above the agar nasi, with cells reaching high anteriorly, or 50% of the height of the frontal sinus. So we are anticipating already that the opening of the frontal sinus may not be very easy. So what we here are doing is that we are basically using a straight Hajduk-Koffler punch to remove the anterior wall of the agar nasi somewhat, so that our working trajectory with the 0-degree endoscope becomes more clear, and we can reserve the angled endoscopes and the angled work for later. So as we remove the anterior wall of the agar nasi slightly, one must be also mindful of the orbit just laterally because that is the lateral boundary of the frontal recess. So as we see here, with the bulla still intact, the maxillary enterostomy being done, we have just opened the agar nasi, both the posterior and the anterior wall, and now we start opening the bulla ethmoidalis to increase our working space inside the frontal recess eventually. Sometimes it may so happen that even if the posterior ethmoid or sphenoid are not involved, they could simply be opened to locate the skull-base trajectory, and sometimes that would be also a reasonable way to follow your way high up into the frontal skull base from posterior to anterior. We are taking a navigator probe now and touching it in contact with the basal lamella. As you can see, we are taking a trajectory which matches the transitional enterostomy ridge, which is this, as you see here, which we are pointing. And the transitional enterostomy ridge points us towards the basal lamella, or the entry point into the posterior ethmoids from the basal lamella. As we are seeing, we are right now using a navigator probe to see where we are with regards to frontal sinus. So here we use our microdebrider blade and matching the location of the transitional enterostomy ridge medially and inferiorly. We take our microdebrider blade to go through and penetrate the basal lamella to enter the posterior ethmoidal cavity. We must be also understanding that the skull base starts to slope downwards from anterior to posterior, as well as the orbit starts to curve from lateral to medial as we go posteriorly. So one must be mindful of those trajectories as the working space becomes slightly restricted anteriorly to posteriorly, and that has to be borne in mind. As we can see here, the first main structure that comes once we come into posterior ethmoidal cavity is the superior turbinate, which is being now trimmed in its inferior half. We leave the superior half normally because of its role in having the olfactory mucosa in it. The inferior half of the superior turbinate head has been resected with a microdebrider blade. One could also do it normally with a straight true cutting forceps as well. Now we are using a Hajek Kofler punch to remove some more bone inferiorly to come inside the sphenoid sinus. As we see here, a small vessel inside the sphenoid sinus as we are opening it, most likely the septal branch of the sphenopalatine artery that supplies the nasal septum, sometimes can get traumatized. And here we're using a standard Pro-Size Max coagulator wand to coagulate the bleeding vessel for us to have a clear vision. One can also use endoscopic bipolar forceps. Now we can see the clear bone of the septum and the vomer right in front of us, which is the medial part of the sphenoid sinus, and we see our probe entering the sphenoid sinus proper. The sphenoid sinus helps us guide our way because that is the lowest point and the median-most point of skull base. And as we see, we can start removing septations and start coming more superiorly as we go more anteriorly. So we can see here, this is the posterior ethmoidal cell, which is posterior, which is lateral and superior to the sphenoid sinus. So we can remove these bony septations in some time. So here we're using Heberhold cranial true cut forceps to map how much bone we have, how much septations we have, and remove the posterior ethmoidal septations to take these septations, remove them, and make these posterior ethmoidectomies flush with the skull base proper. And this is a very important step in almost in all sinus surgeries, because the moment we open the ethmoids comfortably and generously, the patients are able to irrigate, and whether be it polypoidal sinusitis or non-polypoidal sinusitis, it generally helps us in controlling the sinus cavities in these patients post-operatively, and thus maintaining a good vision in the office procedures using endoscopies, as well as preventing chances of recurrences. Leaving septations behind, leaving sharp ledges of bone behind, be it polyposis or non-polypoidal sinusitis, is normally a telltale recipe for failures and disease recurrences. This can often lead to new bone formation, osteoneogenesis, vascular proliferation around these new bone vessels, which could lead to persistent and very refractory headaches and such kind of symptoms in these patients. Once we commit to surgery in these patients, it is prudent that we follow surgical principles and remove as much bony septations very clearly, while adhering to our policies of mucosal preservation and not keeping a lot of bare bone inside these sinus cavities. As we see here, we have removed some bit of the posterior ethmoidal septations. The sphenoid was already open, and now we can see our entry inside the posterior ethmoidectomy cavity. We are just taking the microdebrider blade to slightly widen it. The posterior wall of maxilla is clearly visible here. So as you see, we have widened our access in the posterior ethmoidectomy cavity nicely. And now we once again divert our attention towards the frontal recess. So here we are using again the frontal sinus curette, and we are using gently this instrument to palpate the cells one by one and make sure that we do not use any force, and we are just trying to insinuate our curettes inside within the recess and trying to find the path of recess, which sometimes in these situations where there are more than one cells above the agar nasi can be quite tortuous. So finding the right area or the right plane to where back fracture these cells is very important and must not be taken lightly. As we have seen here now, the agar nasi and the first cell has been removed, and now we are left with again another frontal recess cell. Now, contrary to belief, this is not the frontal sinus that we are in. This is merely a cell, and we need to again find out the frontal sinus. Now, we are just again fracturing the posterior wall of this type 2 or type 3 cell, which sits above the agar nasi. As you can see, we are still working under the axilla of the middle turbinate, inferior to the frontal beak. We have not yet encountered the beak. And you can see a small cell having been opened as we are opening this cell with the curette. Now, as of now, we do not know whether this cell is the frontal sinus per se or not, and we will need more assurance about it. So what we do here is to increase our access anteriorly, without which we cannot go posteriorly. So we take a straight bone punch. Sometimes we can even take a slightly curved DCR punch and remove some bit of bone of the anterior agonizing wall flush with the orbit to be able to again increase our vision inside the frontal recess. The only thing one has to mind in these patients is not to fracture the axilla or not to break the axilla, because then that would lead to a floppy middle turbinate, which would eventually lateralize and lead to late cicatrization or stenosis of the frontal recess. So here we're using a 40-degree curved microdebrider blade to clear some leftover cells and excess tissue inside the frontal recess, while again trying to formally evaluate the anatomy as to where we are before we proceed any further. So just a simple thought that almost every fraction millimeter of space here that we achieve anteriorly is vital for our adequate posterior vision, because if we do not have anterior vision, we certainly cannot work posteriorly. We're using a navigator probe to see where we are, and if this indeed looks like the level of the frontal recess, what we find here, it is not. So here we need to open this much more widely anteriorly to be able to get inside the frontal recess, and for this we use our articulated frontal punch. Now this is again a tricky instrument to use because it's extremely curved, and the moment you put it inside, the visibility goes for a toss. Also, because of its unique curvature, it creates a sort of conflict with the endoscope, and often the moment we have engaged the bite of this against the beak of frontal bone beak, we're not able to see very well. So now we have shifted to a 70-degree camera, a 70-degree endoscope, and using a ball probe to see if they can insinuate the thin ball probe inside the frontal recess. And you can see the frontal beak there clearly. It's a thick beak on which the instrument is being pointed. This is a thick frontal beak. We are working under, we are being inside, under the axilla of the middle turbinate. And this, where the beak is going, is not actually the frontal cell, the frontal sinus, though it might look like. It's still a type 3 cell, which is really under. There's not a suprabullar cell, this is a type 3 cell. So we need to still move anteriorly to be able to work our way inside the frontal sinus. So this is a slight anterior ethmoidal cell is still left open. So we'll first need to remove this anterior ethmoidal cell that sits between us and the skull base. As we see here, we're using a 70-degree camera to see inside that cell. So now we can use a curette or an angular microdebrider blade to basically remove this cell, fracture it again anteriorly to be able to locate the skull base and overall again improve our perspective of the approach towards the frontal sinus. So we see here we are gently using the curette. We are working with a 70-degree camera facing upwards, and we are back fracturing the wall of this cell. And soon, once we have done that, we'll be removing this cell with either a forceps or a curved microdebrider blade. Here we are using a slightly angled black C forceps to remove some bit of the excess bone of this anterior ethmoidal cell that was lying between the bulla and the Kuhn cells. Now we can very nicely see the entire skull base from posterior to anterior with this small cell only impeding our way. So with this kind of a curvature also reassures us as to what we are seeing. We can see the frontal beak anteriorly. We are seeing this cell which is now being removed. And obviously we could see the entire skull base from sphenoid onwards. Here you point here with this navigator probe. This is approximately also the level of the frontal of the anterior ethmoidal artery, the one that was previously touched. And this is the frontal beak. This is the tip of the frontal beak. And sometimes in a patient with thick beak and altered anatomy, this beak has to be removed either with the drill or with an articulated punch depending on individual anatomy and equipment. So here we are choosing an articulated punch to clear some more frontal beak here anteriorly, so that we are able to ingress or enter the frontal sinus proper, which we still have not. As you can see, the moment we articulate with this extremely curved punch, it creates a conflict with the endoscope, and the vision is sort of, it temporarily goes. So it's very important to articulate firmly and clearly, and if in doubt, one has to be very, very sure before we do so that we do not injure any other structure here, most likely the orbit. Since we are articulating anteriorly and not posteriorly, it is very hard to injure the skull base proper unless somehow the instruments get jammed inside, or we try to forcibly remove it. Well, as we have punched out some bit of a little bone with this punch, now you see we again use our curette to see if we have actually entered the frontal sinus proper. Now, as you see here, this was a large T3 cell occupying more than 50% of the height of the frontal sinus, and now we have gone and actually fractured that cell, like this, with the frontal sinus curette, and now we seem to be gaining our access to inside the frontal sinus proper. Now this is extremely skewed vision because we're using the 70-degree camera to see upwards, and now we are actually breaking. This is the wall of the large T3 cell, which is occupying 50% of the height of frontal sinus, and we are trying to again even break that to be able to see inside the frontal sinus proper. As I had mentioned before, every millimeter of space that we create anteriorly is very, very important in overall allowing us instrumentation and vision inside. So we use a shaver blade that is curved 40 degrees upwards to and strictly use anteriorly. Now we must never use this blade posteriorly, because posteriorly we have the posterior table of the frontal sinus and we can create a CSF leak. So using anteriorly, we shave off some excess bone and excess tissue, and now as we see here, we have as we see here, we're still using the curette to even sort of more generously open the recess, because whatever we open now will obviously become slightly scarred in the post-operative period. And for us to be comfortably giving this patient an open frontal sinus, one has to create a reasonably large opening which could sustain eventually post surgery as well. So as we see here, we are still removing the biting of the frontal beak slightly more to give us a larger sort of entry inside the frontal sinus, because part of the fragment of that T3 cell is still not completely removed. And you will shortly see that as we remove some bit of more bone, we'll be getting a more comfortable entry inside the frontal sinus for sure. And the large T3 cell would not impede us then. Each time there's something, we can obviously wash it. And now you see that the actual frontal sinus above this cell is now being opened. So this was the amount of bone that required to be punched was quite a lot. And now that eventually we have opened, the most anterior part of it is actually the frontal sinus. So we need to still open it slightly more to be able to getting a comfortable entry inside the frontal sinus. Difficult anatomy is sometimes a problem. And now we see how more anterior as compared to this cell, we have actually gained access to the frontal sinus proper. So just to revise the anatomy, the most anterior part of it is now the frontal sinus that lies just above the beak, and posterior to it are the your T3 cells. Or as these cells, as you see, these are T3 cell. So it basically means that it is pneumatized above and from anteriorly. You cannot, you have to break these cells from posterior to anterior. But because of this strange angulation, we are not able to go behind this cell since it is so high. If this was a low-lying cell, we could have gone behind the cell and fractured it anteriorly. But since it's a very high cell, when at the height of 50% of the frontal sinus, we are trying to go behind that cell with the frontal sinus, with the back of the frontal curate, which is rather awkward to be able to gain access. But eventually what we have seen is that we have opened the frontal sinus proper and opened these T3 cells as well on the right side. And in absence of any gross polypoidal mucosa, the opening seems to be reasonably good. The exposed bone of the frontal beak, however, would be healing with some amount of granulation in the post-operative period. You could probably use a lot of heavy douching with saline and steroid to try to reduce the amount of granulation that is stenosis in the frontal sinus. Here we come on the left side. On the left side, we are again we repeat the same procedure. We initiate the process with the maxillary enterostomy and uncinectomy. And of course, it is mandatory to remove the most superior part of the uncinate process if a goal of surgery is to indeed open the frontal sinuses. One can use a curved suction, one can use a frontal sinus curette, sometimes a ball probe. All these instruments are good. Here we go behind the bulla ethmoidalis and again back fracture it. Once you are back fracturing, you know approximately your level of base of skull, and the possibility of pushing an instrument inside is very less. So as we go here, even on this side, we are trying to remove some cells superiorly in the area of the frontal recess, though we have not really approached the frontal recess per se. So here we use a shiver blade again to have a reasonably large enterostomy, which helps us gain perspective of the height of sphenoid, the level of the posterior ethmoids, so that we keep our overall 3D perspective in check while doing sinus surgeries in such kind of anatomies. I need a mic on. This is the most superior part of the uncinate process, which is also many times, the posterior wall of the agar nasi, and this is now being removed. And now we can see that we have an access toward the basal lamella as well, which we have right now penetrated using our straight microdebrider blade. So as we penetrate the basal lamella, we also remove the superior attachment of the uncinate process here. We can see the open agar nasi cell, which happens to be just underneath the axilla of the middle turbinate. Plenty of irrigation at the same time keeps our vision good and reduces the surgical time and the surgical frustration of repeatedly removing the endoscope every time now and then to be able to see better. So here we are punctured the basal lamella, we are into the posterior ethmoid cavity. Soon we shall be again encountering the superior turbinate and hence the sphenoid sinus. It is prudent to identify the skull base in posteriorly, where it is low, and then probably one can make your way anteriorly and superiorly, because one knows the lowest point of skull base. We can see some polyps coming out of the posterior ethmoidectomy cavity, which we had already remarked on the CT scan. So here we see there that we're going medial to the superior turbinate here to enter the sphenoid sinus, and of course lateral and posterior and lateral and superior to the sphenoid sinus is our the posterior ethmoidal sinus. So we can see here the superior turbinate inferior portion being trimmed with the microdivider blade, and medial to the superior turbinate is our sphenoethmoidal recess, which guides us towards the sphenoid sinus. Lateral to the same is the ethmoidal cavity. Here we are just enlarging the maxillary sinus enterostomy to prevent any post-operative stenosis. Some bit of posterior maxillary wall mucosa has been peeled off, which we can just incise, cut either using a true cutting forceps or the microdivider blade for it to fall back posteriorly. One must not avulse this mucosa and create bare bone, because then that would lead to unnecessary granulations and scarring. So now once a basic ethmoidectomy cavity has been completed, the posterior ethmoid has been opened, the sphenoid has been opened, maxilla has been opened, now we divert our attention towards the frontal sinus, and here we are taking our curette and trying to move it inside the frontal sinus and back fracturing the tier of cells that compromise the frontal recess in this case. As you must remember, there was a large suprabullar cell that was pneumatizing along the posterior wall of the frontal sinus into the frontal sinus proper, imitating a frontal bulla cell or a type 4 cell, but actually it is not so. It is a suprabullar cell that has pneumatized along the roof of skull base inside the frontal sinus. Now, making this distinction on a parasagittal cut, on a coronal cut, is very, very important, because then that would dictate your approach towards the frontal sinus. So as we see here, once a basic opening has been done, we take our microdivider blade to remove the septation in the ethmoidectomy cavity. We can already probably see our view inside that large suprabullar cell anteriorly, which we will start fracturing if we are to conclusively see the frontal sinus. And this, as you see, is that large suprabullar cell that we had identified, which was going inside, pneumatizing inside the frontal sinus, imitating isolated frontal cell, which in actual reality are very, very uncommon and rare. Mostly the cells that look like isolated frontal cells inside the frontal sinus are mostly suprabullar cells that become large, and they pneumatize anteriorly along the skull base, along the posterior wall of the frontal sinus. It's very important to remember that these cells' posterior wall is same as the posterior wall of frontal sinus. So no attempt must be made to go behind the suprabullar cell, because then if you go behind the suprabullar cell, you're effectively going behind the skull base and trying to fracture the skull base itself, causing a CSF leak. That is why creating clear distinctions between the Kuhn cells, which are anteriorly based, and the suprabullar cells, which are posteriorly based along the frontal sinus posterior wall and skull base, is so very important to avoid complications in frontal sinus surgery. So here we're taking our probe, the frontal sinus turret anterior to the cell, the suprabullar cell that we have already identified, and you can see here, we seem to have entered the frontal sinus proper. Now this cell, as you can clearly see, is anterior to the erstwhile opened frontal bular cell. So rather than going behind the suprabullar cell, we are now working anterior to the suprabullar cell. And in fact, we can back fracture the lower part of the anterior wall of the suprabullar cell posteriorly, a little bit cautiously, so as to locate the frontal sinus and try to merge these two cells for better communication. And now that we have located the frontal sinus anterior to the suprabullar cell, we have sort of fractured the party wall and converted both these into a common cavity, and then that common cavity can be irrigated as well as controlled in the post-operative period endoscopically. Now you can see that once the party wall between both suprabullar cell and the frontal sinus has been removed, we can see them as in totality as a complete joined frontal sinus. This is the overall picture. And we can still try to slightly increase that even more and remove that slight party wall to do that more. One must not go too high, because then again, if you go too high and you fracture the anterior wall of the suprabullar cell posteriorly, then there is again also a slight possibility of creating breach in the posterior table of frontal sinus, which would again lead to a bad situation, because then that will have to be closed, and that risks having CSF leak with less than adequate exposure. But here we are just trying to gently take our frontal sinus turret or any ball probe between the actual frontal sinus and the anterior wall of the frontal bullar cell to remove this. And this wall can be removed after fracturing with a simple giraffe forceps, which opens straight and not sideways. So there's importance of both the straight and the sideways opening giraffe. Here we are following the frontal beak, and we are removing the party wall between the or so-called anterior wall of the frontal bullar cell. And now once that has been done using the curette as well as the giraffe forceps, what we see here is a gross opening inside, a large opening inside the frontal sinus on the left side, where the anterior wall of the suprabullar cell has been mostly removed, and thus we can enter the frontal sinus clearly, and this sinus is now amenable to irrigation with saline, with steroids, and to remove the patient's symptoms to happen because of a very tight constricted frontal recess and frontal sinus opening. So once again, you can see that how important it is to have a clear understanding of the anatomy of the frontal recess and use multiple instruments. We began with a thin frontal sinus probe, and you can see here now with the 70-degree force camera, this is the wall we are talking about. This is the wall of this is the anterior wall of the frontal side of the suprabullar cell that was restricting the access into the frontal sinus. Now we are just behind the frontal beak and in front of the anterior wall of suprabullar cell, and this is where the location of the frontal sinus is, as you can see here. It's quite remarkable how clear one's understanding of the CT scan must be. And as you see here now, our instrument with the angle endoscope is able to negotiate the space between the frontal beak and the anterior wall of suprabullar cell to conclusively open the frontal sinus proper. Now to again gain some space and some instrumentation space, we are slightly removing the frontal beak, again with an articulated punch, because this frontal beak was impeding our vision and our access inside that area. But once we use the articulated punch to remove the frontal sinus beak, we are able to obviously see better, as well as the instruments get a better leverage and better trajectory inside that tight region to be able to do what we want to do, which is basically to remove the anterior wall of the suprabullar cell. As you can see, we are able to push it backwards, but still some part of it still remains, which obstructs our view. But for most part, the opening has been made really wide and patent in our access, and the frontal sinus proper, which was earlier restricted, has also been opened. This is the instrument which is going inside it. As you see here, now with an angled endoscope we are working. We are looking superiorly. We are articulating our punch. We are engaging the lift of the frontal beak onto the punch superiorly and sometimes slightly lateral. One must be mindful of the orbit, not causing an orbital breach, because the orbital periosteum, if it's breached, the fat will start to protrude and will obviously obscure our access and our entry inside the frontal recess and the frontal sinus. Now one must see carefully how well we can see inside this bular cell. And must not forget that the large entry that we see here is inside the frontal bular cell, and this is the anterior wall of the frontal bular cell, which we are negotiating with the ball probe. And though the ball probe is easily going inside the frontal sinus, anterior to this wall, we still are trying to, break the posterior wall of this cell conclusively. And on this side, as we can see here, this is a type 3 Kuhn cell above which we have opened the frontal sinus on the right side. It's reasonably big in size, good and well amenable to irrigation. We are looking upward with a 70-degree camera endoscope. We are right now anterior to the skull base, anterior to the tibiform plate. Our instrument is going inside the frontal sinus on the right side. This is the anterior ethmoidal artery. This is the posterior ethmoidal skull base, the lamina.